Soft cataracts with minimal of nucleus are usually seen in young individuals and have their own nuances and difficulties which are not common as seen with cataracts which are hard, which are seen in elderly age group. So this is one individual in whom we have a central posterior capsular cataract, and as we can see that this is a very small central cataract, but the patient being a healthy young individual who had his own visual requirements had botherations because of the central cataract, specifically the glare. This is the fundus photograph, and this patient had a bilateral cataract. This is the other eye which had a similar cataract, and this is the fundus photograph of the other eye. So starting with making an incision which was planned at the steep axis, which had a corneal astigmatism of 0.5 diopters, which I assumed that I would be able to neutralize it. So making a clear corneal incision in this individual. Now we can appreciate the central posterior capsular cataract, and this kind of cataract is very disabling, especially in bright light like sunlight, and especially the incident light which is seen when the patients are driving on the road during night. So rest of the things are like we inject intracameral lignocaine, and as we can appreciate that these patients would be more apprehensive with heightened senses, so they are frequently having more of blepharospasm and protective ocular movements. The capsule is usually more elastic, so one has to be very vigilant that the rhexis aimed is little smaller, because invariably the capsule is going to stretch and pull the rhexis out, and this is more commonly seen in pediatric age group, but still in this age group also the capsule is relatively elastic when compared to elderly age group. So we have done a nice round capsular rhexis measuring something like 5.5 to 6 millimeters. It's important to make a large rhexis in these individuals because of accentuated post-operative fibrosis which can occur especially in presence of a hydrophobic IOL. Now this trick is very important when you do a hydrodelineation and let the nucleus prolapse out, and this is going to make rest of the surgery very easy because these nuclei don't have any holding facility, that is they are too fragile, and the cheese wiring is too common, so they cannot be chopped, and ultimately if they are prolapsed out like this, then the surgery becomes very fast and very easy. Once the nucleus has been consumed, you go ahead and remove the remaining epinucleus, which is quite thick and bulky in these individuals, and which can be aspirated using the phaco tip, which will take less time. We can appreciate the remnant posterior capsular cataract and the lenticular opacity, which was actually the culprit in whole scenario. Injecting some viscoelastic and now proceeding for irrigation aspiration of the remaining cortical fibers. So these steps are not tricky once you have removed the nucleus, but one has to be especially very sure that none of the cortical matter is left behind, because these individuals will also have more possibility of post-operative uveitis because of more robust immune system compared to an elderly person. So here we are removing the cortex, and the best way to remove the cortex is engaging the anterior end of the capsular lens fiber and peeling it away from the posterior capsule. A tilted and a bent irrigation aspiration cannula will always help in reaching to the sides so as to remove the sub-incisional cortical matter. Preparing to implant the IOL, and here we have planned a monofocal hydrophobic single piece IOL. I usually don't push these patients too much for multifocal IOLs because a crisp and clear vision is far more important from their lifestyle point of view, and use of some amount of glasses may not be that bad, especially if it's a bilateral cataract where you can plan the other eye to be more or less a little myopic, so that binocularly the patient can manage most of the daily tasks using both the eyes open. So the other eye is still planned for surgery, and this eye we have planned for emmetropia, and I expect that this patient would be seeing 6 by 6 without glasses, because I have also taken care of the cylindrical astigmatism because of the corneal curvature. Removing the viscoelastic material. As compared to elderly patients, these eyes can tolerate viscoelastic better because the trabecular meshwork is not that choked. So possibility of post-op IOP rise because of retained viscoelastic is least in young individuals. Now, as the tissues are elastic, so it's very important to properly seal the anterior chamber, and you will see that this chamber is not going to get sealed by routine infusion and IOP preparation. So we need to hydrate the clear corneal incision, then only it is going to seal well. And this is very important for young individuals and especially in the pediatric age group. So even one side of the hydration may work at times. At times one may need to hydrate both the lips. This is the post-op day 1 picture. We can appreciate a semi-dilated pupil because of a mydriatic. The clarity in the cornea is exceptional, and this is the day 7 picture, and we can appreciate the patient has a round pupil, clear cornea, and the IOL which is well in place, and the patient's vision at this moment was 6 by 6 unaided with 2.5 addition needed for near vision. Thank you.